Hello, I'm Jen Letchford, Tissue Viability Nurse Advisor with Coloplast. I'd like to welcome you today to an introduction to wound care. The learning objectives for today's session are to understand the impact of wound healing, the financial cost that has to the NHS. We'll talk about a definition of a wound, understanding of wound types, the structures of the skin, learn more about the stages of wound healing, and underline those basic principles of management of a wound. So there's a change in the wound care landscape. The demographics are changing, workload and workforce are changing again, workforce is reducing and workload increasing. The funding is also reducing, and patient settings and where we deliver that care is also changing. So there's been a huge impact of chronic wound cost and healing. 3.8 million wounds are managed annually by the NHS at a cost of £8.3 billion. The resources that are needed to manage these wounds have also increased dramatically. If we look at district nursing time here, we can see there's been a huge increase in the amount of time that district nurses spend managing these wounds. The same as healthcare assistants. We've seen a huge increase between 2012-2013 and 2017-2018. So more healthcare assistants are helping to manage these wounds in practice. Betty's story. So Betty's story looks at a suboptimal pathway of care versus an optimal pathway of care. And you can see here that Betty is a 70-year-old lady. She identified as overweight at health check. At 74, she had a graze to her leg. And that then took quite significant time to heal because this pathway we're looking at here is this suboptimal pathway. So she went to the GP and got antibiotics. The antibiotics didn't help to improve the wound, and 2 weeks later she then required antimicrobial dressings and more practice nurse time in order to help manage that wound. Once that antimicrobial dressing didn't work, she then had a vascular referral, which again took further time, 8 weeks or so, for her to actually be seen. In that time, the practice nurse was trying to manage that wound. She then deteriorated so much that she could no longer go and see the practice nurse and ended up with district nurses going in to see her. She eventually went into compression but didn't tolerate that compression and ended up with a cellulitis and was admitted to hospital for 5 days. After various treatments and various therapies and various hospital appointments and admissions, she eventually healed after 2 years at a cost of £5,673. If we now compare that to an optimal pathway of care, at 70, when Betty initially went to the GP and was seen and that risk identified of her being slightly overweight at her health check, she was able at that point to be given compression hosiery to try and prevent any leg ulceration. At 74, when she then grazed her leg, she visited the pharmacy. And as per the lower leg pathway, she was seen by a practice nurse and 2 days later had a full assessment and ABPI. 5 weeks later, the treatment had worked and the ulcer had healed. Betty continued to wear that compression hosiery in order to prevent further breakdown and was then given an annual lower limb assessment. She healed within 6 weeks from start to finish at a total cost of £505. So you can see here the difference between suboptimal care and an optimal pathway of care. The potential impact of these chronic or hard to heal wounds can be huge. So the physical pain, for example, that a patient might experience can have a real impact on their day-to-day living. Odour, infection, exudate, bleeding and itching, or unsuitable clothing potentially if they're wearing something that might be irritating at that wound. They might have a loss of function and not be able to be as productive as they otherwise would be. You then have these really personal impacts the thoughts of shame because they have the wound, uncertainty around how long it's going to take to heal, the inconvenience of having a wound and having to go to various appointments. They might feel quite isolated because of this wound, or have a lack of mobility associated with the wound, and overall, a poor well-being or low self-esteem. So this is Fleming, and Fleming is a wound care patient of Coloplasts, and Fleming recognised that within a very short period of time, if exudate isn't managed, it can delay wound healing and cause quite significant pain. So what is a wound? A wound, the definition of a wound would be a breakdown in the protective function of the skin. So different types of wounds. There are numerous types of wounds, but some of the most commonly seen are venous leg ulcers, pressure ulcers, diabetic foot ulcers, or maybe even a surgical wound. So wound types and their etiologies. We can split this into two areas. It can either be acute wounds or hard to heal chronic wounds. Acute wounds generally consist of these surgical wounds, incisions, donor sites, or traumatic wounds such as a burn, skin abrasion, or an accident. You might have a skin tear, for example. Hard to heal chronic wounds would include those things such as venous leg ulcers, arterial leg ulcers, diabetic foot ulcers, pressure ulcers, and actually they're the more complex wounds to manage. So some skin facts for you. The skin is the largest organ in the body. It renews itself every 28 days. The thickest skin is on your feet, and that's about 1.5 millimetres in thickness. And then every minute, 30,000 dead skin cells are shed. The main functions of the skin are to protect, to maintain our body temperature. They help with sensation and what we can feel, our metabolism and communication. So when we split the skin into the structures that lay within it, it helps us to understand how that can impact on wound healing. And it's really essential that we do understand this in order to help us with our wound assessment, for example. So when we're looking at the skin, we can split it into three areas: the epidermis, the dermis, and the subcutaneous tissue. So the structure of the skin, you can see here, and if we start with the subcutaneous tissue, that's that bottommost layer of skin. Then we look at the dermis and the epidermis on the top. You can see a variety of structures that are within the skin and within this organ. So some of the factors affecting that skin barrier function could be very dry skin, excess moisture to the skin, the pH levels of the skin, again, if they're disturbed, then it could cause an impact on the functionality of the skin. Neonates, or the effects of ageing. As we get older, the skin becomes drier and can actually be more at risk of breaking. Now we'll go into some wound healing and looking at the stages of wound healing.
In every wound type, the healing process runs through a cascade of phases, which partly overlap in time. The immediate reaction to injury is a contraction of the capillaries to reduce bleeding. Red blood cells and platelets released from damaged blood vessels flow into the wound, aggregate, and produce a plug or clot in the wound. The first step in the inflammatory process is dilatation of the capillaries. Increased permeability of the capillary allows serum and white blood cells to migrate into the wound area. Here, the white blood cells differentiate into different cells, including neutrophils and macrophages. Neutrophils and macrophages are attracted to the damaged cells and bacteria by chemical substances. They become phagocytic and engulf dead tissue and bacteria. Once all the dead tissue is eliminated, the inflammation gradually subsides. During the proliferation phase, the wound is filled with granulation tissue. Granulation tissue consists of newly formed capillaries and connective tissue. The formation of new capillaries, angiogenesis, ensures that nutrients are supplied for granulation tissue formation and is essential for wound healing. Fibroblasts are the predominant cells in the proliferations phase. They migrate into the wound site from the surrounding tissue and start to multiply. In the last part of the proliferations phase, the wound is made smaller by wound contraction. Wound contraction is brought about by specialized fibroblasts with contractile properties called myofibroblasts. When the granulation tissue filling the wound is almost at level with the surrounding skin, re-epithelialization starts. The epithelial cells change shape to facilitate locomotion and crawl across the wound bed to cover it. Migration stops as soon as cells regain contact. The cells change back to their normal appearance and reattach themselves to the basement membrane. The wound is closed. The transition from granulation tissue to scar tissue involves reorganization and maturation of collagen fibers to maximize tensile strength. During remodeling, the fibers are orientated along the lines of tension and cross-linked to form a strong wound. Remodeling can take up to 2 years after wounding.
So hemostasis, the first stage in the healing process. And this is what happens at that initial break in the skin. It's where bleeding will occur and a blood clot will start to form in that wound bed. You'll see some inflammation at this stage, but that's not inflammation linked to infection, this is inflammation linked to this stage of wound healing. We then move into the inflammatory phase of healing. And this is where you have an opening of the blood supply. The cleansing of the wound starts to happen as part of the natural process of the body. You may at this point have a formation of a scab, but those hard to heal wounds tend to get stuck in this phase of healing for various reasons, and that could be because of infection. We then move on to proliferation, and this is where the cells start to replicate and you have that new tissue growth. Cells will start to migrate across the wound and new capillaries start to form so that you have a new blood supply in the area. That new collagen tissue is also laid down at this point. We then move through that stage into the remodelling stage of healing, which can take up to 2 years. Scar tissue, when it's there, is only 80% of the strength of the skin prior to the injury. The collagen starts to form, which increases that tensile strength, but that will never go back to the same strength that it was prior to the injury. So the stages of healing that the body goes through are the same for both acute and chronic wounds. What you will notice is that actually the inflammation in the chronic wounds or hard to heal wounds, that phase tends to last longer. There will be an overlap in these phases of wound healing. So, how do wounds heal? They can either heal by primary intention, which is the closing of the wound, normally within hours after the injury, and it's where the edges of the wound can be brought back together. Then we have secondary intention healing. This is where the primary closure isn't possible and where a wound should be left open to heal spontaneously and would go through those stages of healing that we've just discussed. So healing by primary intention could use sutures or clips. This is the normal process with those surgical wounds that you might be seeing, or those uncomplicated acute wounds. It's not suitable for long-term chronic or hard to heal wounds. We then have the healing by the secondary intention, and this is where the body is left to heal the wound from the base up, meaning that you have this new capillary formation as seen in the video earlier on. This is used with those chronic or hard to heal wounds that we discussed earlier on, and it wouldn't be a suitable way of healing for those primary intention, those wounds healing by primary intention. Wounds healing like this do transition between healing stages, as I've already mentioned, and the inflammation stage can be prolonged either due to infection or other complication. Complex wounds should be monitored really closely by trained staff and experienced, skilled staff able to manage these wounds in order to try and keep the costs down for these wounds, but also give the patient the best possible outcome. And I'll just make you think back there to Betty's story and that optimum pathway of care. That required really skilled staff to be able to support that patient. So wound types and their characteristics. The acute wounds, normally short in duration, they have that normal inflammatory phase with no underlying pathology. They usually heal without complication, and the wound fluid will support that cell proliferation, but won't cause excessive exudate onto the peri-wound skin, causing further delay and breakdown. We then look at those hard to heal wounds. And these would class as the wounds that haven't really progressed within a four-week period and definitely not healed within 8 weeks. So they would have that prolonged inflammatory phase. They would have an underlying pathology or disease associated with their case, and a variety of complications can arise from that. Wound fluid does not support that cell proliferation. We might have too much wound fluid, too much exudate, and again it's really important to be able to manage that wound exudate. The wound fluid, if it's not managed, can start to damage that wound edge and peri-wound skin, causing further delay and breakdown. So our aim of wound management is to help the body to facilitate the optimum healing environment. And that can rely on our understanding of what's going on with that wound, and really it's key to have a thorough wound assessment in place. Which leads me on to the Coloplast 3-step approach. And this is really there to try and help simplify our approach to wound management. So the first step in this process is to assess, and a really thorough, robust assessment will help us to help our patients. We then move on to step 2, which is to prepare our wound. And we want to be able to prepare the wound bed, edge and peri-wound skin and help to create the optimum healing environment. Step 3 is then our dressing selection or our treatment. And we want to be able to select a dressing that will help to manage those points that we've pulled out from our wound assessment. So looking at assess in slightly more detail. Why do we assess a wound? Well, it helps us to identify a cause or breakdown of the skin. Why did that happen in the first place? And what can we do to try and prevent that from happening again, but also remove that reason in order to help this wound to heal? We look at any identified risk factors and try and correct any or treat any underlying causes. Identify appropriate treatments. It helps us to control that wound-related symptom or symptoms that the patient might be experiencing, and prevents further breakdown of the skin and the wound. We can also help to identify here our patients' expectations of wound healing. How involved are they in their care? Are they suitable to be on a shared care pathway, for example? Would they like to be involved in their own wound management? And that's something that we can discuss with our patient from the very start at their wound assessment. So what happens if we don't get it right? Well, we've already discussed Betty's story and we've seen the difference that an optimum pathway versus suboptimum pathway can make. Failure to identify the wound etiology will result in slower wound healing. The inability to identify any barriers to healing, again, will slow that healing process down, meaning the patient is living with the wound for longer. It could also lead to inappropriate treatment choice, increased costs, and real dissatisfaction from our patient. So we need to be using a holistic approach and holistic assessment tools to help support us with our wound assessment. And these will take into account numerous things such as fluids, nutrition, oxygen, pain levels of the patient, immobility, their smoking status, any underlying diseases, and any medications that they might be on that again could be having an impact on their healing. So at Coloplast we have the triangle of wound assessment, which helps us to look at the patient as a whole, as well as the specifics of the wound, being the wound edge, the wound bed and the peri-wound skin. Once we've completed our thorough assessment, we move on to this prepare phase, which is the second step in the three-step approach. And we want to be able to prepare or remove any dead and devitalised tissues from that wound bed, edge and peri-wound skin. It will prevent the epithelial cell migration if there is dead and devitalised tissue in the wound or on the wound surface, and it can block the delivery of any topical antimicrobial agents that we might be wanting to use. It can also hinder that wound assessment, so it might be that we need to prepare our wound and then go back and reassess that patient. If we don't prepare the wound, then we'll have delays in healing, which will lead to increased costs and also detrimental outcomes to our patient potentially. The dead and devitalised tissue can also increase the risk of infection for our patient. So again, it's something that we really need to be thinking about and questioning whether we are sufficiently preparing our wounds. So what do I mean by wound preparation? Well, wound preparation is this concept and holistic approach, systematic approach to removing any barriers to healing. When we're thinking about debridement, debridement is defined as the removal of the dead and devitalised tissue or non-viable tissue within a wound. Once we've prepared our wound for healing, we then move on to treat. And this is where we need to think back to our assessment and look at our treatment objectives. And they'll help us to identify which treatment or which dressings are appropriate to use with our patient. We might be thinking of using a dressing, for example, to manage exudate or maceration. We might be thinking that the patient has a biofilm or suspected infection, in which case the treatment that we select is really important to be able to manage what we've identified. If we have any depth or a cavity to a wound, what are we best to use with that? How are we going to manage that for the patient? We know that managing the gap is really important to prevent this exudate pooling and proliferation of bacteria. So we need to be conscious of that as we're selecting an appropriate treatment. When we come on to the dressing selection, there are various different types of dressings available to us. Knowing what each one does is really essential, and it will help with our management of the patient and management of the patient's expectations, as well as help support that healing process. So some of the commonly used dressings you can see listed here, and we're going to go through each of these in a bit more detail. So foam dressings. Foam dressings can be appropriate for use either in low, medium or highly exuding wounds. Again, we need to think about why we might be using that, and are we using it to manage the gap, for example, that dead space in that wound bed. If that is the case, then are we selecting a dressing that will conform into the wound bed, or do we need to use another dressing as well? But foam dressings can be used as primary or secondary dressings. They'll help to absorb that wound exudate and help to maintain that moist healing environment. They can be combined with retention bandages or compression, for example, if that's necessary in order to manage your patient's wound. Some foam dressings will contain active ingredients such as silver or ibuprofen. So again, it's knowing what's on your formulary, what's available to you, and the specific details of that dressing is really important. We then move on to hydrocolloids, which are appropriate for low or moderately exuding wounds. They can be used as primary or secondary dressings. Their semi-permeable top film layer allows that transmission of oxygen and water vapour, but also acts as a barrier against water and contaminants, bacteria for example. Alginates can be appropriate for use with sloughy wounds or moderate to highly or heavily exuding wounds. They do require a secondary dressing, so it will need something over the top of this. On contact, these dressings turn into a cohesive gel, and these fibres are really absorbent and help to manage that wound exudate. Some of them can contain silver for infected wound management or wounds at risk of infection. So, gelling fibres. These are appropriate for wounds greater than 2 centimetres in depth that might have some slough, or moderate to highly exuding wounds. They require a secondary dressing and they resemble alginates. On contact with exudate, this gelling fibre swells and forms a soft cohesive gel. They might contain silvers or active ingredients in order to help support or manage infected wounds, for example. We then have contact layers. Contact layers are appropriate for low, medium or highly exuding wounds. They can be used with an absorbent secondary layer or under compression. And they protect that tissue from any trauma and allow the exudate to pass through them into the secondary dressing. Hydrogels are appropriate for dry, sloughy or necrotic wounds. We don't see as many of these in use these days, but they do still exist. They must be used with a secondary dressing and may be used throughout the healing process to provide that moist healing environment. We then move on to topical antimicrobials, and I already mentioned that you might find topical antimicrobials impregnated into either foam dressings or some of the alginates or gelling fibres. But there is a whole array of antimicrobials that we can access. These are things like honey, PHMB, iodine or silvers. And they all work in slightly different ways. And again, it's really important that you understand what you have available to you and how that works. So our learning objectives for today were to understand the impact of wound healing and the financial cost and burden that has, the definition of a wound, the understanding of different wound types and wound etiologies, the structures and functions of the skin, and to learn about the different stages of wound healing. So I hope that you found today's session useful, and I'd like to thank you again for joining me.